Okay. Apparently, we're ready to go from Chennai. So I'm just going to introduce the panel. I'm Gareth Morgan from Denver. Next to me is John Carroll, also from Denver. Then we got Martin Box from Rainbow Children's, Brian Murray from Seattle, Ralph Hirsch, and then we've got a non-interventional person. So please be nice. So Antigone Derry from Leeds in the UK is a echo and interventional imaging expert. And then unfortunately we have to tolerate Shaq Qureshi as the facilitator. So anybody looks like they're going to sleep or is on their mobile phone, third row on the right, mobile phone. Anybody on their mobile phone is going to be woken up and abused by Shaq. It looks like we've got a very light program from the point of view of Sivakumar, who does 4 cases every 12 minutes usually. So we're going to have 4 cases from Siva and his lab, and we're going to start off with hopefully a mitral paravalve leak closure. So Siva, are you with us, and are you ready to start your first case?
Hi Gareth, good afternoon. And how are you all in Frankfurt?
All good here, Siva. We're having a good morning, so we're looking forward to some entertainment from you.
Superb. So, without wasting much time, I thank the organizers for giving me this opportunity. And can I request for the PowerPoint to be shown? Yes.
Yeah, good morning. I'll be presenting the case. The patient is a 31-year-old lady. She's an educated and she's software engineer now. She was having second MAST with severe MR and PAH, for which she underwent an initial surgery at 12 years of age. It was in 2005. She underwent AST surgical closure with a pericardial patch and MB replacement using a 27 millimeter valve with tricuspid annuloplasty. After 11 years, she developed prosthetic valve degeneration, for which she underwent a redo surgery. During the surgery, the sternotomy was considered to be difficult because of the anticipated adhesions, and she underwent through right anterolateral thoracotomy. And she was, after 1 year of the second surgery, she presented with dyspnea again, and when we evaluated her, we found that she was having mitral paravalvular leak. Next slide, please. This is in 2017. She was having a large paravalvular leak in 9 to 10 o'clock position. For that, we did a septal puncture. You can see the first image, which is showing that the septal puncture is likely to be difficult because of lot of staining because of the pericardial patch. And once we were able to do it, we could cross the leak antegradally first, advance the sheath, and then do a paravalvular leak closure using a PLD device. Next slide. A 10x4 device was used. The residual leak was crossed retrogradely from the arterial axis, and then we snared it, and finally the second device 10 mm AVP2 was deployed from the venous axis itself. Next please. We can see that there was a significant elevation in the LA pressure with a V of 40 and a mean of 25, which decreased after the procedure. Next. She was doing well for next 5 years, but later she developed atrial fibrillation, which was not medically controlled initially. We tried episodes of cardioversion, but finally she ended up in permanent atrial fibrillation, and she is currently on rate control medications. Now she is having again worsening symptoms in terms of dyspnea class 2 to 3 with increasing need of diuretics. Clinically, she is still having atrial fibrillation. She has a grade 3 mid-diastolic murmur and a pansystolic murmur. Next. We can see significant cardiomegaly with LA enlargement. The ECG, next slide please. The ECG was showing atrial fibrillation. I think there's some problem with the slides.
Is it they're working? Okay, Gareth, the patient had, as Pramod was mentioning, a previous glutaraldehyde tanned pericardial patch. That pericardial patch hardened a lot, which gave us difficulty in 2017, where when we were doing a septal puncture, we found it very difficult to cross, and we had to use electrical cautery to enter into the left atrial septum. And then subsequently, the patient remained stable, and once she started getting atrial fibrillation, progressively she was getting more and more breathless, and the valve started having significant stenosis. Yeah, Pramod, you can go ahead.
Yeah, one slide previous.
Are you able to see the slides?
Yes, we can see your slides.
Yeah.
When we did a repeat echocardiogram during the worsening symptoms, we found that the bioprosthetic was again degenerated with thickening, and there was an increasing gradient with a peak of 27 and a mean of 13 at a heart rate of around 80 per minute. There was a combination of mitral valvular mitral regurgitation and also significant paravalvular leak, which was again present, and it was lateral again in location. The LA was aneurysmally dilated. The live echocardiography will be shown now, so I am not describing much about the echocardiography. The problem now is the patient was having labile INR, and she was on anticoagulation because of AF, but she was having significant menorrhagia and episodes of anemia requiring medications, and sometimes she was discontinuing vitamin K antagonist because of the menorrhagia. So we plan for a TMVR. The CT analysis, we can see here the LA is hugely dilated. The valve location is not usual. We can see here the valve is more pointed towards the septum, and this is the Thimencio analysis, which shows that the aortomitral angle is relatively acceptable. It's around 37.5. The inner lumen of the inner perimeter derived diameter of the valve is around 22 millimeters. Next. This is the procedural simulation with VR. We can see here this is the VR software that we are using from Poland called VMRSave. Here we can see the on the first image we can see that the valve is more en face rather than anteroposterior. It's more of anteroposteriorly located, and then you can see that the curvature, if the wire is placed, how it looks like. Actually, the wire will be more going leftward, and then actually it has to dive downwards. So we anticipate some degree of difficulty in advancing the valve, and we are considering some options for stabilizing the leaf, stabilizing this wire. And we can also see here, once we place if we place a valve, the LVOT should be decent. The neo LVOT with a 24.5 valve was acceptable. It was almost 600. Next, please. This is the procedural. Now we actually, after doing a transeptal puncture, we recorded the gradients from live cath now. That is, these are the images that we recorded now. We can see that there is a significant elevation in the LA pressure with a prominent V wave and a reasonable amount of gradients.
Okay, so what we have seen now is the same patient who is having a laterally located mitral paravalvular leak. So let me go on live full 3D echocardiography. Srija is our imaging expert, and she will be now demonstrating a few recorded pictures of the transesophageal echo just now. This patient is now on full anesthesia, intubation, and with the ventricular rate somewhere around 70. Now, Srija, over to you.
Good morning. So I'll quickly take you through some of the images which I acquired in the cath lab. So this is first image is showing the degenerated bioprocesses with a inflow gradient as well as a mild regurgitation. Also, you can see that there is a lateral paravalvular leak. This is a like because of the abnormal orientation of the valve. Also, the leak. This is the direction of the jet.
The aneurysmally dilated left atrial appendage and leftward part of the atrium is actually tilting the mitral valve more towards medial part of the interventricular septum. So actually the orientation of this valve is in such a way that in a CT it was more in a coronal plane, and it was directed directly anterior towards the left ventricular apex. The left ventricular apex is directly anterior to the mitral valve orifice.
Shiva, can you hear me?
Yes, Shaq. Good afternoon.
Yeah. Quick question. I'm trying to clear my head. Are you planning to occlude the paravalvular leak first, or are you going to do the mitral valve replacement first?
See, the mitral paravalvular leak is planned to be closed first, because it will not be possible to over expand the mitral prosthesis to squeeze out this mitral paravalvular leak, because this has been there for some time. So our plan is to first cross this mitral paravalvular leak, put a plug, and then go for a mitral transcatheter mitral valve replacement. Actually,
also practical question. Then, are you crossing both the valve as well as the paravalvular leak and placing wires inside, or are you going to do one and then the other?
In order to make it less confusing, our plan is to go paravalvular leak retrograde, and obviously transcatheter mitral valve in valve antegrade. So that means through the transeptal we will address the central lumen of the valve, and through the retrograde aortic catheter we will go paravalvular.
Okay, it's unusual for you to make it easy for yourself.
Yeah. Stephen,
Okay.
can I just to follow up on what Shaq said? Did you think about, and would it be so? Okay, this is a 25 millimeter Biacore, which has got an internal diameter of 21 millimeters. Therefore, did you consider maybe cracking the frame of the Biacore so you can get a decent sized mitral valve in, and then thinking that you may well have eliminated the paravalve leak by doing that, or is that too crazy?
No, I think that's a very valid point. Now the problem about doing a mitral valve cracking, unlike a pulmonary valve or a tricuspid valve cracking, will involve a sudden worsening of the hemodynamics, and there may be an acute left atrial pressure elevation, and unless we are super rapid and to get the valve across, sometimes there can be a brief destabilization of the patient created by the acute pulmonary edema created by the severe paravalvular leak. So we considered that, and what we decided was we will take a 24.5 millimeter valve, deploy it in the usual location, and then post dilate it with a 24 millimeter Atlas Gold balloon, the mid portion, and try to make it full 24. We also thought about
during that, do you worry about the circumflex coronary artery, or what, do you do any protection?
No, Shaq. Actually, it was we made some more CT pictures. They were the coronary sinus, the circumflex artery were all quite at a distance, Shaq. They were not of concern. Okay. I mean, anatomically it is clean. Now let me myself put the challenge of this patient. She's only a 30-year-old lady, and she's already in atrial fibrillation. So one of the main question will be, why not do a mechanical valve replacement? But when we went through the previous surgical notes, when she got first time operated for an ASD and a mitral valve replacement because of a very severe bad MR long ago, and following that, when she developed a degeneration of the first tissue valve, she had a lot of sternal adhesions, and so the surgeon decided to go right thoracotomy. So now that she is now gone into permanent atrial fibrillation, so she is going to need anticoagulation. We are not able to push the anticoagulation to very high levels that is needed for a mechanical valve. Like for an atrial fibrillation with the mechanical prosthetic valve, I need 2.5 to 3.5 INR, and she starts having severe menorrhagia even if the INR touches 1.8, 1.9. So quite often we are actually like playing with subtherapeutic doses of warfarin. We give warfarin to maintain her INR at around 1.8, and during the menstrual periods we stop it for 4 or 5 days, because otherwise she will get into terrible menorrhagia.
So, and Shiva, Raphael is going to ask a short question which will need a short answer.
Yep.
Try it. Oh.
Hi, Siva, it's Raphael.
Hi, Raphael.
I wanted to ask you, hi, if you go transeptal for the valve, why should you go retrograde for the lateral leak? Because lateral leak is better from the septum usually. I
agree, but now you look at the picture, Raphael. Can you show the TE live? You see the position of the paravalvular leak, Rafa. It is directed from the leftward wall, skirts around the base of the left atrial appendage, and it skirts around. This is 11 centimeter left atrium. So if I have to come antegrade and try to cross it, I have to go all the way, bend my Agilis catheter, and then try for it. Instead of trying from an aneurysmal 11 centimeter atria, I thought we will try from a smaller left ventricle where the crossing will be a little bit more easier. And anyhow, the transeptal puncture is positioned in such a way that it is easy for my transcatheter mitral valve in valve, which means I am going very, very, very postero-inferior. If I have to go for this mitral paravalvular leak, which last time I did, I went in much more at a superior level, so that I will be able to dive. Now here intentionally I am going very low. I am going very low and posterior. So having
how much have you done so far?
Okay, actually since we had to give heparin, I had to do a transeptal puncture. So let me show you the transeptal puncture. So here now this is the transeptal puncture being done. You can appreciate on the first picture, the leftward picture, it is very posterior, and in the right picture, which is the Y plane, it is very inferior. And now I will show that on an echo navigation. Can you show the echo navigation? Actually, Shaq, we have not closed the paravalvular leak. The paravalvular leak is still open, but the wire, once I got the catheter into the left ventricle, now this is live. Show the echo navigation. So I will now show you the pictures. The red color and the yellow color markers that we are seeing were the markers that we put on the postero-inferior part of the atrial septum. Then the mitral paravalvular leak, we again used echo navigation, and that echo navigation, that one we put yellow, white colored and green colored markers. Once we got that, then when we gave, actually we punctured the atrial septum, and then we got a 8.5 French Agilis inside, then we gave heparin. When we were trying to get the hemodynamics, now show the hemodynamics. When we were trying to show the hemodynamics also. Take this volcano out and show the hemodynamics. Yeah, so when we were recording the hemodynamics, this is on full anesthesia. We can see some amount of mitral gradient. LA pressure is hovering around 18 to 19. And when we advanced the Judkins left coronary catheter into the left ventricle, the guide wire entered into the left atrium through that paravalvular leak. I didn't want to pull it out. I just left it there. Now, Srija, can you show me the guide wire position? Yeah. Srija is now showing live. Echo big.
So you crossed the paravalvular leak accidentally, correct?
I would say little bit of some. I was actually trying to, that echo navigation dots we put it, and then I was trying to find out which guide wire will enter, and then the guide wire entered, and so then I left it as such. Now what we are seeing live, what we are seeing live is the guide wire going through that paravalvular leak, and so that is the paravalvular leak. You can see part of the guide wire there. So we have a guide catheter in the left ventricle, the side arm of which is recording the LV pressure, and we have already made a transeptal puncture, and there is a pigtail in the left atrium. That left atrium is recording the left atrial pressure. So this is where we are currently. So our intention now is to go in and cross this paravalvular leak. See that is a paravalvular leak.
So it's in a very different position. Well, it's in quite a different position to your original paravalvular leak. It looks quite distant to your previous devices.
Yeah, it is. It's a little bit inferior and posterior to that, Gareth.
Got you.
There is some. Actually, if you look at Srija's echocardiogram, you will find that this paravalvular leak is actually in very eccentric. You see that the catheter is now going not directly into the left atrium, but actually skirting around some. It's much more going laterally. It's a very. So now get me an 8 mm vascular plug. Actually, the paravalvular leak RFI is measured somewhere around 5 to 5.5 mm. So we are planning an 8 mm AVP2. So Shaq, any thought processes?
Any suggestions, Kevin?
Hi, Kevin.
Yeah, I mean, it's certainly gone, very lateral, there, but I assume you can see it on echo quite well in terms of your guide cath position.
Yeah.
What are you implying?
Well, it just seems, it's probably just, it's such a huge left atrium. I think that's probably the case. I think 10 mm vascular plug seems fine. That's a 6 French guide, isn't it?
Yeah, 6 French guide. It easily takes an 8 French. If it is a 10 mm AVP, it will struggle a little bit. So I am going for an 8 mm. I will try to.
I'm just going to ask Alison.
Hi, Alison. How are you?
Hi, I'm good.
And
nice
paravalvular leak person from Mayo.
On your own in the fine. The first echo picture, and I apologize, I haven't seen all of the pictures. Is the leak really more crescent-tech in its shape? Is it rectangular? And do you think you'll need more than one device, like sequential?
No, Harrison, it was not so large. Originally, when I did the procedure long ago, at that time it was much more crescentic that I had to use a 10 into 4 Occlutech rectangular paravalvular leak device, and I had to add a 10 mm ampulature vascular plug. This happened 2017, but this time this leak was not so big. This leak was just measuring about 5 millimeter. In fact, we have done multiple echocardiograms between 2017 when I closed the paravalvular leak and the present one. We couldn't identify a significant paravalvular leak in the past, but now this was identified recently when we were evaluating her for the next mitral valve replacement. So now I am actually coming. In order to prevent it from getting just pulled through.
Yeah.
Can you make it larger? Can you make the picture larger? Zoom so that I take a cine. Yeah, much larger. Now, can you?
Shiva,
Yep,
Shiva,
yeah,
I'm just trying to work out on the 3D.
Yeah.
If you can get somebody to use a cursor and tell us where you think or where they think you
Srija,
are.
use the cursor.
This is
Yeah,
the
now
device
Srija
now.
is showing.
This is the device which is getting deployed.
Yeah. Can you see Shaq? She's showing with an arrow.
I think it's tricky, Siva, isn't it, to know whether or not, just because of the, as you said, the path
Contrast.
of this paravalve leak, it's difficult to know whether all of the device is currently on the left atrial end of this or whether you've managed to drag it into the ventricle at all. I don't know what you think.
Correct. Actually, the fear is how I deployed all the lobes in one of the side. When I try to push, see that is a paravalvular leak. I will now freeze it, bus. Freeze it.
Yeah.
Okay. So that is the paravalvular leak. And okay, now go to LAO orthogonal projection. See this paravalvular leak was very sort of eccentric in another orientation. Go LAO cranial.
That's all in the.
Adding to the agony is that this valve, the Biocar epic valve from the St. Jude has very poor radio opacity, and so make it magnified. Okay. I'm not see it looks like I have a long tunnel. Can you see it now?
Because you're in the LA, aren't you? Well,
yeah, it looks like that. So now what I will do is under
and it's too small for occluding the appendage.
Yeah, and that is not my intention also.
This is a nicer angle, Siva. I think this will be more helpful after that last angiogram, won't it?
Yeah, show that last angiogram once again. Yeah, so now here it looks like this is a long tunnel. We are getting some orientation of the direction of the device. So now, okay, now what I'm going to do is, I'm going to peel my sheath. I will do it on cine so that.
So just keep a little bit of negative tension on the device and then unsheath the device with some negative tension on it. Is that the maneuver you're going to use? Looks like it.
Yep.
Yeah, it's very nice.
That looks much better.
Lovely.
So now I'm repeating. It looks fine to me now. So what I will do is I'm going to release the device now. It looks okay, Gareth?
Yeah, I think it looks
so.
Yeah.
Hold on, Shiva.
Yep.
On the what does the color look like? That's
yeah, color.
Srija,
can you get the color? Nice color. It's less, Shaq.
It's less, yeah.
Yeah, because it's a vascular plug, so there is no fabric. So and I have also given good dose of anticoagulation after my septal puncture. So I am.
My main question was whether I would have gone next size up, but this looks all right as well.
Okay.
So
Now,
it's very constrained nicely.
I will tell you the problems that we anticipate in the transcatheter mitral valve in valve. Can you come to RAO position? RAO. So I have got an Agilis now. I have got an Agilis now. Safari ready. That is lying in the left atrium. So can you go to that profile view? 72 something. Show the Agilis also. So now I am turning my Agilis. I am turning my Agilis towards the mitral valve. Okay. Can you hold it in this with this rotation? So I'm trying. Yep.
Question for you. This is Martin Box. Do you ever use a buddy wire in case you have to cross the second time? Do you use that technique ever, or you're comfortable with your initial size choice?
About the mitral paravalvular leak, right?
Right.
Yeah, actually I would have used the buddy wire if it was a large leak, but since this was not a very large leak, I decided that an 8 mm vascular plug is good enough to close it. So I didn't use any buddy wire. It was not.
My second question.
It was not so large.
Right. My second question is when you were initially deploying that, were you using fluoro or using the 3D TEE?
When I am crossing it, I am using echo navigation. Echo navigation. Okay, show this this echo navigation picture. Can you see the echo navigation dots that I had put it? Make it larger. Make this picture larger. No, that echo navigation larger with echo nav. Okay. Can you see here the echo navigation dots that I had put in? It was that white and green markers. So that was the region. So primarily use that to cross. Is that the question?
Yeah, I think that it does.
Okay. Now I show the last fluoro. So what I did was with the Agilis I advanced the mitral pigtail. Yeah, show the LV apex. So now I will just make one LV angiogram to see whether I have reached the apex now. Srija, I am through the valve, no? Okay. So at this point I am going to give a safari. Now before the safari, I have got a plan on the safari wire because it's so aneurysmal. I anticipate that I want a snare here.
Yes, sir.
I anticipate that.
Long sheet?
Yeah. So I anticipate that the safari wire may come out because of the aneurysmal left atrium when I am going to push the this one. Push the mitral valve towards the mitral orifice. So I'm going to snare the safari wire in the left ventricle. So for enabling that snaring, I am now taking this guide catheter out and I'm going to advance 6 French long shuttle sheath inside the 6 French long shuttle sheath inside the left ventricle, and I'm going to snare the get the 6 French long shuttle sheath.
But Siva, if you're going to snare the wire, why are you using a safari?
Safari gives
the
curve, and so it won't be hurting the left ventricle. The other option of using something like a Lundquist will be the tip may hurt. So Safari has got the advantage of being it's a curved wire. So I think I probably will be good on. Okay, mag down.
And Shiva, just a step ahead, I probably missed it. Which valve are you planning to put in?
I mentioned that it's a balloon expandable valve. It's called my valve. It is similar to Sapien.
Yeah.
The pigtail has come out. Okay. See, while I was talking to you, the pigtail came out. Now I will recross.
Sorry, that was our fault.
Yeah, but
Can Alison get the mic?
Okay, I'm recrossing. Hold it. Okay. While I was concentrating more on the retrograde sheath,
Sorry.
my hand
Sorry,
pulled out the
Shiva.
mitral pictet.
It's Allison. I have a question for you
Hi,
because
Allison.
you have the Agilis there. So why not just try to deploy your Safari wire because the Agilis maintains that curve. And then maybe if you fail, which I'm certain you will not, then you can snare it and show us all of your
I will
other
show you.
dexterity.
I'll show you, Alison, why I'm advancing the pigtail. Actually, my aim is to get this the shuttle-like sheath in the left ventricle. Now I'll show you what I'm doing. So now I'm getting my snare catheter inside the left ventricle. I'm going to get a large snare. I'll show you in a couple of seconds. So I'm going to open out a snare and now I am going to try to get this. So can you keep tightening it? I'm going to try to get this pigtail. Can you tighten it and see? Okay, open it.
And I'm assuming you're not going to do a circuit, but just grab
Not
the
a,
wire
not
and
a,
maintain
not a circuit,
it.
not a circuit, just to stabilize so that the Safari doesn't bulge out.
Yeah.
Okay. Now this needs to be.
Left ventricle is bigger than you thought.
Okay, so Siva, this is more for the audience, but what you're doing is basically snaring the Safari to hold it in place in the ventricular apex so you can keep a bit of push on it rather than making a circuit. I think, is that the strategy? Have I got that right? Yeah.
Correct. Now you catch and see, Pramod. Got it?
Yeah, got it.
Got it. Now you advance the pigtail deep inside. Okay. Now get me the Safari wire. So basically, Gareth, I don't want the Safari wire to jump out of the left ventricle into the left atrium and prevent me from deploying the valve, because this is very aneurysmal. This is a 11 centimeter left atrium. You saw the position of the. Now what I'm doing is I'm advancing my Safari wire.
Yeah.
The moment my Safari comes out, see now itself you see what is happening. So
Yes. Yeah.
1 second.
Yep.
So
Okay. Why? Yeah. No, he's going to.
this is what I wanted, Alison. You see that it was very aneurysmal. Okay. Now can you hold it?
Oh gosh, it's even pushing you back with the wow.
Yeah, it's the left atrium, isn't it?
Yeah.
No,
That is.
push this sheet inside.
You push this.
Sheet
This is
inside.
the septum. This is the sheath.
I suppose it doesn't matter though, because as long as he's got it snared, then if he could push it down, it'll
Like
still.
this because of the ankle.
Not going to be easy to.
Okay. Now
Because of the size of the left atrium, it's not going to be easy to push it down.
Okay.
Yeah.
Now
It'll push laterally.
I'm doing that. Actually, I'm trying to get the valve. Okay. Now. Okay. Hold it. Hold it in the LV apex. Okay. So now.
You're just trying to slip onto the tip of the wire and snare it again.
I'm trying for that.
Yes. Oh, come on. We've all got our fingers crossed.
The problem is the catheter has run out of space
Oh, damn. Yeah.
because it's a 90 shuttle with a 100. Let me see.
We're almost there.
You're
I
getting
still
it.
got
Well
it.
done.
Okay. Now
Very
what I
impressive.
will do is I'm going to pull this guide wire towards the apex and draw my pigtail. Okay, it's happening in the other direction. Okay, hold it, Tejasvi, here. Okay, I will now bend the agilis.
Which brings me back to Alison's point, which was have the agilis through to the left ventricle and then less chance of it bouncing backwards.
No, it is not so easy, Shaki. This is because the agilis is actually directing the catheter more towards the leftward side. It's not, this valve is oriented very differently. This valve is oriented more towards the interventricular septum. So now I am trying to
Mario, any suggestions?
Well, I wonder if the agilis is not bended enough. Now it's bending more. So it's getting a bad direction towards the left ventricle, right?
go to LAO. Go to LAO. Mario, actually, Srija, can you show me that 14th or 15th image, the orientation to Mario, the picture where the left and the one of the picture there we showed that mitral paravalvulic, I think 16 or something. Yeah, you see, Mario, the direction of the paravalvular leak is, this is it's directed leftward. The valve is oriented more medially. Now I am trying to advance the pigtail.
The valve orientations from the appendage towards the septum.
Yeah, this is see how it is. This is LAO. See the direction that is this.
Anil.
Hello. Good evening, Dr. Shiva.
Hi, good
evening. One question. Is there any possibility of hybrid or direct transapical access?
I will get it, Anil, don't worry. Just give me some time. Okay, come to RAO. No, I can let go of the whole thing and then again go back and re-snare. The problem that I'm finding is
Shiva, that was a brilliant question from one of your former trainees and colleagues.
No, I can understand the anxiety of Anil, because Anil has been one of my longest associates, like for many years. Okay, now see, okay, so what I will do is I will let go of this and I will try to recross. So I'm getting the.
I don't think you've got anything to lose by trying to get the sheath across into the left ventricle before you snare it, the agilis. You've tried this method.
No, but I think I see Siva's point that the angle that the agilis is going to have to make is extremely unnatural. You're going to have to swing all the way around the left atrium and then come back towards the septum, which you don't really have any. All your push and pull is going in the wrong direction.
Yeah, your forces.
Tried the logical method.
Yeah.
Try the illogical method.
Yeah.
Or the other possibility, I suppose, would be to snare the wire and oversize the sheath. To maintain the sheath in place with a second wire or an 014 wire even.
Actually, I am not able to get my Safari. The Safari wire is not coming out.
Yeah.
Let me see. Okay.
Maybe push it off of the catheter. Yeah.
Okay.
Got it. Okay.
So now I will go back to. Can you go back to that RAO view? Profile the mitral valve. Yeah. So here I'll come.
May I just do a silly comment or a silly suggestions? If you don't think that a Safari wire is enough to get the sheet following to the left ventricle? Why not to put two
Come to AP.
stiff wires?
AP, get another
To give
Agilis. This
extra
Agilis is
support.
twisted.
I
I'll
was
show
at
you
the
the.
wrong sheet.
Get me down the RAO. See the problem that I am facing is this Agilis is twisted at that
oh, you've
angle,
knackered.
and so
yes, it is.
it is not obeying like the rules of Agilis. So what I will do now is I will try to
buggered.
undo it. Let me see again one more attempt to flex. Yeah. Okay. Come to RAO.
I was actually wondering, Mario, if the stiffness of the Safari wire was hurting in this particular instance, because any force directed along the length of the venous sheath was pushing laterally towards the dome of the left atrium, and the stiffer the wire, it takes the ability to actually curve and direct the Agilis sheath. It wants to straighten the Agilis sheath, whether a softer wire paradoxically
now
more useful.
Now I am going to again try it out to get the snaring. So what I am doing is I am opening out the snare and I am advancing my pigtail. Snare it and see, Pramod. Okay, open it out. I'll again reopen and snare. Snare. Super.
Keep it here.
So this is a much better position. So what I will do is I will orient my Agilis and can you hold it with the turn? Okay. Now give me the Safari. Okay.
Nicely done.
So now release this one snare and go distal and catch. Okay. Now I am taking out my pigtail. Okay.
Yes.
Pigtail, and you are catching only the Safari.
Yes.
Now you have to release it. Okay. Catch it again. Tight. Very tight. Okay. So now get the flossing. Come to AP view. Get the. Okay. I will hold it for you. Okay. Now what you do is you take out this pigtail out. Pigtail out. Okay. Okay. Now you Tejasvi, you take over on the left side. So you are holding this. Get me a 2 post here so that I don't have a bleeding. Your Y adapter. Start crimping. Y adapter.
Take one more. It's okay.
Thank you. Open it.
By the way, for the audience, this counts as two cases because the first one was a paravalvular leak and the second valve
Open
in
it
valve, so
nicely.
this counts as the two.
So basically, to prevent a bleeding back from my the snaring catheter, I am getting a. Pramod, can you get it inside?
I'll get it.
So we can't quite see. You're just putting a TUI on the back of the guide. Is that right?
Yeah,
Or the
for
shuttle?
TUI, correct, exactly. Because I
Okay.
need. I don't want to bleed a lot.
Yeah, got you. Well, she's already got menorrhagia, so you have to be careful with that.
Yeah. So now I'm flushing this left ventricle. Okay. So now. So what I'm going to do now is I'm going to advance the flossing balloon, which is now we have chosen a Atlas Gold for the transeptal. So this is an Atlas Gold. Is it 14 millimeter? 14. So I'm now getting across the Atlas Gold 14. I presumably I would have crossed the septum. So now I am relaxing the agilis, and I am coming out. Inflate the balloon.
Ready to inflate?
Little bit inflate.
Yeah.
Perfect. Yeah, keep inflating. So now actually I am inflating the atrial septum, the pericardial patch. So this is going to be quite challenging. So I'm getting
Raju?
it. You have to keep it well.
So this was the ASD that was closed, was
that
it?
ASD which was surgically closed. Yeah.
Yeah.
That'll be a third case exactly. So
okay. So now you have fully inflated.
Up to 12.
Okay. So now I'm going to floss the balloon. I will.
Shiva, before you take this out.
Yeah.
Oh, too late.
No. It's I am flossing so
whether
that
you should
deflate.
Whether you should advance the balloon through the valve and then use the balloon to advance the sheath.
yeah, but he's got the wrong sheath. He's got the wrong sheath.
No, the
No,
sheath.
it gives you a little bit. Then you can do the next step.
Next, yeah. So basically,
I want to go
take all
inside.
this out,
No, once
reload
again,
the
deflate.
atlas over the
Deflate
balloon, over the valve sheath, and then use that to pull the sheath across. Yeah.
This is now across the mitral valve shack. Come to RMO. Come to RMO.
Because if this crosses, then you can use your whatever sheath you want to use for the my valve.
No, that sheath is
And
very
use-
short sheath, shack. It's not long sheath. It just
Oh, I
goes
see, all
only. It goes only into the groin. Okay, open it. So this is.
okay.
I am now doing a mitral valve balloon angioplasty, but with a small balloon. It's only 14. Okay, now you continue to hold it.
So
Continue
you
to hold
don't have
it.
dry seal or anything.
No, we don't have. Okay, now I am flossing the atrial septum. It's quite tight, very tight. Okay. Deflate fully. Python sheath ready. Python sheath is something like an E sheath. It's an expandable sheath. So what I'm planning to do is.
I didn't ask for a TOE to show the atrial septum.
Yeah. So
just a comment about
Pramod,
the
come here
groin
and
sheath
hold
for
the
these
agilis.
mitral valve in valve, whether you should put a 26 French dry seal in. So if you have a problem delivering the my valve, you're able to get it out. And with an E sheath, is going to be a lot harder.
Any big sheath except an E sheath. Yeah.
Okay. Kevin,
centrant at all.
Kevin, I fully agree with you that if given an option, a 26 long Gore dry seal would have been good. Gore dry seal is not registered in our country, so we have to live with lack of.
And Medtronic centrant or nothing?
No, centrant is more rigid shack. It will not turn at all. It will not take this turn at all.
Yeah, I mean, Kevin's making the point more for rescue the
rescue
valve, because if you try and pull the my valve back through an E sheath, the E sheath it'll be destroyed.
Python.
But if you if you had a short 26 or something of anything.
The Python has got a sheath that is 26 French, but that is a very rigid straight sheath. It won't have any curve, and it will not curve at the atrial septum, take a right angle and try to enter the mitral valve.
No,
it is primarily meant.
It's more for rescue, if you not to get you all the way through the valve.
I agree with you. So now what I am doing is, I have advanced the Python.
That means he doesn't have it.
I don't have a Gore dry seal. The Python large sheath is not useful for crossing the septum shack. It won't cross because it is a straight sheath. So what will happen is, it will pull out the guide wire even if I am holding it in the left ventricle into the left atrium, because it's very straight and very rigid. So now I have got the short Python sheath ready. Python sheath is an expandable sheath. So now I have loaded a 24.5 millimeter my valve. It's a 25 millimeter Biocar Epic prosthesis. So
Siva, as you put that in, does this delivery system have the same controls that the Edwards Commander system has? And can you put flex on this to help you around that quarter?
Yes. We can put a flex. We can put a flex. Or holding?
Holding.
So now I have entered the short sheath. So my valve is now entering into the.
Move this a little to the top, or do they do that at the other end? Ask.
So this is the valve. So now this valve now has to.
Shiva, ask them to move your picture to the top left.
Okay, no, my picture can go to the top left.
Or tell them we don't need to see you.
I mean close the camera. Camera not necessary.
No, that's good.
Okay.
Very good.
Pretty impressive,
Okay.
Shiva. Well done.
So now, okay. Now what we are going to do is it fully loaded? 20 ml nominal. Just add 1.5 ml, 1.5 ml more. Quick. So basically, this is a 24.5 ml valve, 24.5 millimeter valve, which has got a nominal size of around 20 ml. Correct?
No, I'm giving
20. Now I am giving 1.5 ml extra so that I get another little bit, 0.5 extra.
And then just talk us through the landmarks in terms of positioning this valve.
Yeah. So now my intention is to go maybe 30% inside the LV, 30% in the LA and 70% in the LV. See that I will show you now. So this is what is the current position. Make it okay. Center the valve. The screen, correct. Now you go slow. I want you to slowly expand so that I get a control. Slowly keep expanding. Yeah. Okay. Yeah.
Hold that slow,
Full,
do you?
full now. Full. Empty it. No, full.
You mean
Full.
push?
That flaring of the valve on either side is very important. Okay, don't they deflate now? Deflate. Okay. Now fluorostore this entire thing and replay. Okay. Now get ready. Atlas Gold 24x4. So now see this is the valve deployment. Now I have the whole my valve assembly inside. So what I'm going to do is Pramod, come here, control the Python. So now I am slowly trying to take the valve out.
Not the valve.
I mean the okay.
See,
Balloon.
you just said control the Python, which in most countries wouldn't mean anything, but because you're in India, then it makes sense. You get Pythons in India?
Yeah. Plenty.
Okay.
Especially in
You're
Chennai.
having control here.
Yeah.
Huh?
Yeah.
Okay. Atlas Gold ready. Atlas Gold.
How does the 2D TOE look?
Yeah. 2D. Srija Echo. I have got a very rigid safari wire going through. Put the color, Srija.
Yeah.
Okay.
Right now there is
This is
some
a
leak, but it's
24.
because of the wire across.
Okay. Srija, you can keep describing while I am advancing the 24 Atlas.
Yeah, there is some regurgitation, maybe because of the hardware across.
Get the valve in the center. Maybe put an explain on the valve.
Yeah. See, but while you look at that, are you going to try and use a 24x2 centimeter Atlas?
No,
or a
no. It's a
22x4
long
centimeter?
24x4, so that balloon doesn't jump up and down. So
And
now,
I always find that a difficult decision because you could end up getting a lot of dog boning in the balloon and not focusing the pressure on the bit of the valve you want to expand, which might just shorten your valve without a lot of help. But then the 2 centimeter may not be stable, so I think it's a tricky decision. You'd rather have the stability of the 4.
I think that's reasonable to try.
keep slowly going up. No need to be in a hurry.
Yes, sir. Going slowly.
No, wait. Deflate. Okay, now slowly start inflating.
Hurrying is relative, isn't it?
But actually, deflate.
It's not paste, so it's like
Can I
Probably
do
need
the
to be a
balloon?
bit-
Okay. Yeah, just
See,
hold
you
it
don't
together.
trust them.
Yeah.
Why there is no like air inside? Okay.
See, but Kevin was half joking, but he suggested snaring the tip of the Atlas gold balloon, which might give you really good stability.
Yeah, we'll do that. Once again, I'm just getting the air out of the.
He's going to inflate the balloon himself.
Yeah. Now.
See, he's done it.
Okay, now tell the number.
4, 6, 8, 10, 10, 8, 10, 10,
Very good.
10, 12, 12, 14, 14, 14.
That should get rid of the paravalva leak, if
Okay,
any.
fluorostore.
Yeah.
Okay, now I'm going to take this out so that the Srija gets an opportunity to
There's no
see the valve. Get a pigtail inside. Soft pigtail, 5 French.
Absolutely brilliant, isn't it?
You got a really lovely response on that valve frame with that 24 Atlas. That's really great.
If I take out the Safari, I will get a better valve function assessment on echocardiography.
Yeah, we forgot to check that you loaded the valve the right way around, of course, but hopefully that was okay.
How does the color look, Srija?
Yeah, and right now there is some regurgitation, maybe because of the wire.
Yeah, wire
I think
there,
we'll
yeah.
have to assess after all the hardware is out.
And whilst you're there, what about the paravalva leak? He squeezed it.
Okay,
Oh,
so now
tiny bit.
Srija, there is nothing stiff across, only a pigtail across. Can you now see an echo? One second, let me see.
Yeah, so
LV gradient alone.
Huh?
LV gradient.
the position looks good.
Yep.
How is the valve looking?
Yeah.
Looks okay, Shaq.
Yeah. Yeah, it looks, tiny bit of...
Tiny bit, a little bit of regurgitation.
Yeah.
Okay. Okay. So
Are you able to get an idea of the gradient at the moment?
I will. Get me another RCA or some catheter for LV, LA simultaneous.
Thermo, please.
Then I'm assuming you're going to leave the ASD alone in case you need to come back.
Mean of 3 on echo.
Huh?
Transmittal mean gradient of 3.
Srija, Srija, I think you should be audible for the. Okay, see the
Shaq. Mean gradient?
Mean is 3 millimeters of mercury.
Okay, all right.
That's pretty good.
Show your color and if possible. Let me see whether I have LV pressure. Take it out. I will take out the pigtail now so that I can have a clean LV, LA hemodynamics. Thermo wire.
Is there something across the valve? Pigtail is there, still there.
Pigtail is there.
Oh, okay.
So I'm going to take out the pigtail.
Yeah, maybe that's why that
Now
eccentric.
nothing is there.
Yeah.
Can we see one simultaneous?
Yeah.
I want to flush both the transducers so that we get the pressures correct.
That looks brilliant.
Yeah, now the leak has disappeared. Like.
Gone, yeah.
Look at the gradient. Brilliant. Well done.
And probably didn't need a paravalva leak device because you squeezed it all out anyway.
Yeah.
Okay, now open both.
Raphael wants to see the ASD on TOE.
Yeah, I'll show it now. I'll show it. Okay, now get a parallel LALV. hemodynamics big. Srija, now it's a good time. No, nothing is across.
We have already shown there is no regurgitation. The inflow looks good. Like
put it on 25 scales.
Absolutely no regurgitation.
Yeah. It looks good, Shaq.
It does indeed.
Check. Actually,
really
we are running out of time. I'm now going to the next lab. Pramod will quickly take one figure of 8 here. The plan will be figure of 8 stitch on the right femoral venous access. Srija, show the ASD. Tafa wanted to see ASD.
Atrial septum, yeah.
Okay, I will pull back from LA to RA so that so you can see the hemodynamics. This is LA pressure, which is around 15.
Raphael, it's small.
Now I have come to RA. This is RA pressure. RA is about 10. Shaq, actually the ASD looks not very large, Shaq, I think over a period of time it may get scarred more. We are moving to the next lab where we are showing the pulmonary valve implantation. So
this was a brilliant case. So well done to the team with you. Well done.
Well done, guys. That was brilliant.